calls, and a new friend, Michelle Patrick, who is kind enough to fill in today for Nora Super, who is out sick. Today's webinar, New Visions for Long-Term Services and Supports, the Aging Network and the White House Conference on Aging, was developed by GSA and supported by a grant from the SCAN Foundation, which is an independent public charity devoted to transforming care for older adults in ways that preserve dignity, courage, and independence. Let's see. Let's begin with a few housekeeping items. First, this webinar is being recorded, and we'll be emailing you an access link once it's available on the GSA website. Also, question and answer session at the end will begin once all of the speakers have concluded their presentation. We'll be accepting questions throughout the webinar, though, through the questions feature accessible on the right side of your screen. We'll also be live tweeting this webinar using the hashtags #WHCOA and #LTSS. You can also follow follow us on Twitter at Geron Society. So, before we get started, I'd like to do a quick poll to see who's in our audience. You should now see the poll displayed on your screen. Please select one response and then click the Submit button to lock it in. We'll be quiet for just a moment while you read through the choices and make your selection. I hope everyone has voted. Do we have the results? Okay, here we go. It's pretty evenly split, I guess. The other is the big question mark, but we've got a good showing from academia and the Aging Network. That's great. A lot of government folks, and that may mean that you're actually part of the Aging Network indirectly, and some healthcare providers, which could be a range of things. Thank you for doing that. Let's go to the next slide. I hope you're aware of today's agenda, but if not, here it is in basically one sentence. If we could go to the next slide. Okay, I'm not able to see the next slide, so I'm just going to go ahead and dive in here and introduce our speakers. You can find their formal bios under the Handouts tab, so I'll keep the introductions brief. Our panel today features Larry Atkins. I've known Larry since we worked together on the Senate Special Committee on Aging many years ago for Senator Hines. He was one of the architects of the 1983 Social Security reform. He's played roles in healthcare reform and other key milestones, including serving as the executive director of the recent Commission on Long-Term Care. He's a nationally recognized leader, and we're pleased to have him with us today. Amy Gottwals will be our second panelist. Amy is a rising star in the Aging Network at the national level. She's a leader among her peers in the Leadership Council of Aging organizations here in Washington, D.C., is one of the strongest and most steadfast advocates for the Older Americans Act that I've ever known. She joins us today from the National Association of Area Agencies on Aging, who are very lucky to have her here representing them in D.C. As I mentioned, Nora Super was forced to send a substitute today, but we're very pleased that Michelle's able to join us. But let me mention a little bit about both Nora and Michelle. I think right now Nora has one of the toughest jobs in town. She is, well, I guess maybe except some of the candidates for president. I would say this is not going to be our parents' or grandparents' White House Conference on Aging. It's a new model with no funding from Congress, no delegates from across the nation, and no list of recommendations to vote on. But Nora and her staff, including Michelle, in their quiet and brilliant way, have led the 2015 conference into history with 5 regional forums, several issue-oriented forums, and the main event scheduled to take place here in D.C. on July 13th at the White House and broadcast nationally. They will have included more participants than ever before, and the president this time will actually be making policy and change, which he's famous for, that very day based on their good work. So we're very fortunate to have Michelle Patrick join us. She is the communication director for the White House Conference on Aging, and she brings with her 20 decades, that would be good, 2 decades of experience in communications and aging issues. Prior to her appointment, Michelle served as the Deputy Communications Director at the Centers for Medicare and Medicaid Services, CMS. She also served as Communications Director for the Merck Institute of Aging and Health, and as a senior speechwriter for former HHS Secretary Donna Shalala. Thank you again for stepping in at the last moment, Michelle. So thank you for joining us all today. And Larry, let me ask you to start us off with the panel.
Thank you, Brian. So I'm going to talk today a little bit from the perspective of the National Commission, the recent Federal Commission on long-term social services and supports, but also a little bit post that, where some of this takes us. And the Long-Term Quality Alliance, which I oversee now, is taking many of the recommendations from the Commission and trying to move them through to more of a reality. And so I will talk a little bit about that. I wanted to start just briefly with the first slide with a couple of just basic grounding statistics here. And this first slide is really more to give you a sense of proportions than it is to give you absolute numbers, because the numbers, as you know, we get sometimes very different numbers from different surveys, and some of these surveys are a little older. We have more recent surveys where the definitions have changed a little bit. So it's sometimes the inconsistency of definitions still remains a bit of a problem here in trying to establish absolute numbers. But the point of this slide is just to say, when we talk about long-term services and supports, although I think a lot of the focus today is on the aging population, it's always good to keep in mind that almost half of this population is under age 65, and that's a very diverse population with a lot of different needs. But I think the slide is also useful to understand that the bulk of the people who are in need of LTSS are not in institutions. So a relatively small percentage are in institutions. Many of them living in the community and needing supports and services in that context. Let me go to the next slide. The next slide, please. Thank you. Okay. So this is from the most recent survey, the NHATS survey that has 2011 data, and it's one of its limitations is it's a point-in-time survey at this point, because we haven't gotten data from subsequent surveys, but it will eventually be a longitudinal survey and will give us a better sense of how the population that needs LTSS changes over time. But I think the statistics from this are interesting and revealing and open up some, I think, new understanding. So basically, this survey just applies to the population of 65 and older, and more than 3/4 of that population has some limitation in self-care or household activity ability. Now, the limitation in self-care sort of tracks to ADLs, and the household activity ability sort of tracks to IADLs. But about a half of the 65 and older population has limitations, but manages without assistance. That's an important piece that I think we haven't really had a good sense of before. 30% accommodate to this limitation or reduce activities. And accommodation may mean things like putting handholds in bathtubs and things like that. 20% have difficulty accommodating. So I think it's important to recognize that there's a population out there that is not showing up with assistance, but is a population definitely in need of some assistance. So it's not being served currently, and I don't think we've had a good count on that population before. So then, a little over a quarter of the 65 and older population gets assistance from others. Only 10% of that is in nursing homes. So we have a population of about 1.1 million in nursing homes. 15% is in supportive care, and 75% is in community settings. So that, I think, tracks to the earlier slide that you saw on the prevalence of community settings for this. And then I think this is instructive. For those outside of nursing homes, 65% of them are receiving unpaid care only. So the 65% are dependent on family or friends or others for assistance. 5% receive paid care only, and 30% are receiving both unpaid and paid care. So there's a relatively small proportion that is not receiving any kind of assistance from family or others. And I think this also points to how substantial the reliance on family caregiving is for this population. Next slide, thanks. Next slide, thank you. And this one just points to, and again, it's older data. I think we'll see probably bigger numbers when we get to the end of this year with new data coming online. But I think the important point here is that over the next 40 years, the population, the number of Americans in need of long-term care, and this includes both the under 65 and the over 65, will double, will more than double. And that is going to put a substantial challenge, for us in trying to figure out how not only to organize care delivery, but also to finance it. The next slide, please. Thank you. So, I think this is an opportunity. It says need for service delivery reform. I'd almost say opportunity for service delivery reform. We have a combination of things coming together here. One is we have a lot going on with new payment models in the healthcare side, particularly coming out of the Affordable Care Act, that put clinical providers at financial risk for the whole patient and populations over longer time periods. And they set performance incentives around patient outcomes. So these systems, and some of these are the accountable care organizations, which are new systems of care that are organized around hospitals and physician groups, where the hospitals and physician groups themselves take substantial risk. And they're taking risk for whole patients. So the patient that they're having to address is primarily living outside the context of the medical care system, which they organize and control. So service delivery increasingly for this population is going to involve, a broader number of organizations involved in providing care, and in a very different role for these payers as they go out and address this population. And I think the growing fiscal challenge for Medicaid LTSS financing, which is, again, largely a function of the very substantial growth in the population that's going to be needing LTSS. But it's driving a search at the state level for savings and efficiencies in the long-term services and supports space. And so there's a tremendous need to find opportunities in the way we deliver long-term services and supports to eliminate duplication and unnecessary costs and kind of the inconsistencies that arise and duplication that arises when we have this care as siloed as it is now in different sectors. The potential for if you begin to manage this population well, and this particularly the more complex care part of the population that is has multiple conditions and is more expensive in the medical side to serve, the potential to generate Medicare savings and outcomes improvements from more effectively managing these conditions and doing that in a way that involves recognizing and addressing the needs for long-term services and supports. And then the persons and caregivers themselves, need more support to handle the growing complexities of arranging and providing LTSS and the transitions that are involved. And very often in our system now, as compartmentalized as it is, individuals and their families are struggling with having to make these, find these services, make these transitions without a lot of support. Okay, the next slide, please. So the Commission, when they looked at this set of opportunities and the challenges of a system of care that really is not a system, and has a lot of inadequacies in the way we're serving people, but also expense and lack of resources. Made essentially a number of recommendations. These are kind of three key recommendations. One was that we should develop a comprehensive array of person and family-centered, high-quality, fiscally sustainable medical and social services and supports that can meet the heterogeneous needs, preferences, and values of individuals with cognitive and functional limitations. So that's the population that we need to serve, and we need to figure out how to array individuals' needs in the least restrictive setting consistent with their preferences. And then I think what we find with this particularly the senior population is a very strong preference, and it's even more so actually in the younger disability population, very strong preference for having that service and support in the home setting to the extent possible. And then integration of LTSS with medical and health-related care that enables a more effective management of transitions between one type or level of care and another. So to try to find ways to span across these silos of care. Next slide, please. Okay. So the components of what we think of as integrated LTSS then are, these are some of the components. There are others, but things like a single care plan that spans the silos of care, the different sectors of care, which would include, which would be based on an assessment of functional need that use standardized definitions and data items. We find now, a world of assessment instruments that use very different definitions and terms in the way they collect data. There needs to be some standardization based on the goals and preferences of the person and family, that should be the starting point for developing a care plan, and where the care plan is shared with all care providers. The need for team-based care with a single point of contact for the family and care and the person, and with a care manager, a single care manager, an integrated health information technology platform that includes LTSS, bringing LTSS into the integrated platform, quality and outcomes measures that are based on individual goals and preferences, patient and caregiver access to information, and financial integration that enables risk sharing among health and LTSS providers and accountability for population health in the aggregate. So those are kind of aspirational goals about what we'd like to see in an integrated delivery system. There are a lot of challenges. I'm not going to spend a lot of time on this, but and many of you are quite familiar with many of these. But acute care and long-term services and supports are two very different cultures, different worlds. We define the needs in the medical system in terms of diagnoses and we define the way we provide care and everything in terms of encounters. When we get into the world of long-term services and supports, we're talking about functional capacity. We're often not talking about trying to improve the person's health or getting a cure or anything. We're really talking about helping the person to maintain the highest quality of life possible and the greatest degree of independence possible, and managing to maintain control over their life for as long as possible. We have a world of community service providers that are plagued with small budgets, being based on appropriations that are scarce. The services are labor intensive and they're very low tech. It's a very different world. There's a danger in integrating LTSS in acute care that it becomes reconceived in a medical context. It's really important in this process that it be built around the family and the individual in their setting and on their goals and their preferences. When we get outside of Medicaid, there really are very few adequate affordable insurance coverages to pay for LTSS, so integrating LTSS in an acute context doesn't bring a lot of resources with it other than Medicaid. So most of the projects right now to do integration involve Medicaid and Medicare and what we call the dual eligibles. There's a need for capital for major investment in IT and quality improvement and workforce development, and that is not coming at the moment and will need to come in the context of integrated delivery. And then quality measurement is really still in the early stages, and we're not sure exactly what we're measuring and how to measure it. Next slide, please. So, I don't need to say too much about the financing crisis. Medicaid pays for 60% of it now, and it is perceived by the states as being a growing burden. Family caregivers actually provide most of it, but they will become less available as we go forward due to the demographics. Most people are arriving at their senior years without a lot of resources, and being able to finance an expensive or lengthy period of LTSS is not within the realm of the possible. And younger disabled individuals really have few options other than through Medicaid, and that requires essentially they leave the workforce to get them. Next slide. So anyway, I want to wrap this up quickly. If we look at how we might go about thinking about financing LTSS, I think it's important to start with a couple of principles. One is that family caregiving is the foundation. We have to make sure that we provide support for family caregivers to keep them involved. Individual responsibility is an important component, and we have to provide individuals ways to use their resources more creatively in order to bring them to bear on this. And then we have to look to public programs to step in when the risks are too great to reduce the uncertainty, cap the risk, and provide a safety net, as we do now with Medicaid. Next slide. Okay. So I will just say very simply, and we can come back and talk about this in questions, that the first step really needs to be to deal with this very extreme risk that's out there now that is open-ended and keeps insurers, private insurers, from being willing to step into to insure the more immediate risk because of the inability to kind of know when you can stop this. So catastrophic insurance would be useful in pooling that very, very high risk. It's a difficult thing to sell to people. A public role is necessary somehow to pool the risk and ensure that extreme risk because of its open-endedness. And there are ways to structure it as reinsurance or federal risk pools or other things that wouldn't require individuals to purchase policies. Next slide. Okay. One way to deal with the intermediate risk, and I think an increasingly promising way, is to look within LTSS integration for the opportunities to realize savings on the acute care side from providing services and supports, and that and the potential to be able to capture within the existing healthcare premium dollar some of the expansion of services into long-term services and support space, and it would bring to community-based organizations a different and less limited financing source for their services going forward. I think there's a lot of wishful thinking in that, and there needs to be a lot more work done around how, in the integrated context, you can recapture those acute care dollars and savings. Next step. Next slide, thanks. So where do we go from here? I think we need to better understand the costs involved in financing catastrophic insurance and some of the other approaches that are out there for bringing financing to it, and I think we are moving in that direction over the next year and a half. We have a modeling project going on now that will produce some estimates around different options so we can start to have that discussion. We need to build the business case for LTSS integration, which can demonstrate that you can lower total health care costs if you provide well-targeted, well-managed LTSS. We need to find ways to ensure there are adequate measures and safeguards to ensure outcomes and quality in integrated plans, and that means we have to do the work to figure out how to measure quality. Broader stakeholder support for a solution. going forward, and we need to start to demonstrate models that can work at the state level and develop a base on the Hill for going forward with this conversation. So that's where I hope we'll go. And thank you.
Thank you, Larry. That's really a great foundation for this discussion, and a number of people have wondered if all the slides are going to be available, and they will be available. I'll talk a little bit about that later, as well as a link to look at the webinar again. Amy Gottwals, you're up. Thank you.
Great. Thank you, Brian. Hello, everyone. On my first slide, well, actually the next one after that, I know at least 19% of you don't even need this slide, and I'm hoping it's 100% of you, but might as well start from the basis, the National Aging Network and our long-term mission. I'm going to talk a little bit today about the dramatic changes that are happening in the LTSS and particularly the HCBS, Home and Community-Based Services landscape, and what that has meant for my organization and how we are trying to respond to the needs of our members and what we think that may spell for the future, and echo a lot of what Larry already did so well in covering the incredible landscape of what's out there, what the challenges are, and where the opportunities are. So full disclosure, I represent the views of the National Association of Area Agencies on Aging. We are just one key part of the Aging Network. So a lot of my slides will really talk about what we know about area agencies on aging from a survey funded by the Administration on Aging over the past several years, and so that's my niche. I'm recognizing there are many views across the Aging Network and even broader in LTSS world that would also be able to weigh in on these things as well. But at M4A, I would say a few themes emerge for us when we talk about advancing LTSS policy. First is the movement towards ever-increasing levels of person-centeredness. How can we continue on that path? I think our inherent nature as the Aging Network has always been focused on meeting the person where they are, ideally there in the home and community, and helping them then age in place. But I think we're learning new things from the disability community, and just as the needs of today's older adults and tomorrow's change, we can continue to do more that's person-centered. Really starting from a planning perspective, and we certainly obviously support Aging and Disability Resource Centers, which have a key role in that. The information, how can we continue to do better at giving people information when they need it? Obviously, ideally before they even need it and their family or their individual is in crisis. Another theme that emerges for us is this increasing need to coordinate services. Coordinate within home and community-based services, but as Larry pointed out, increasing importance of making sure we can coordinate people's care with the acute healthcare side without losing our souls and our fundamental mission. And I also think it's important that despite those large numbers of Medicaid being the largest payer, that we need to keep talking about how to invest in non-Medicaid programs as well, such as the Older Americans Act, because if 78% of people 65 plus have some limitation per Larry's slide, we've got a much bigger problem, and we shouldn't have to have people of all income levels essentially to tell them you can impoverish yourself before you're able to get help. So my next slide outlines what N4A has experienced through our members over the past 2 to 3 years. There's been incredible landscape changes because of the changes in healthcare, pressing changes onto the LTSS side, particularly, obviously, for my folks, the HCBS side. We've had to diversify funding. There's been less funding to go around, but ironically, we've needed to find it in more sources because of the loss of traditional funding, whether it was state lost dollars during the recession, and then, of course, as soon as that was rebounding, you had the compression of federal fundings and reductions through sequestration and the budget caps that we're still continuing to feel the pain of today. But at the same time, not only are area agencies on aging serving more people, but they're also starting to serve broader populations. I've got some slides to demonstrate just how much we are able to serve people under age 65 who are struggling to find HCBS as well. Now, we already knew that before the Affordable Care Act, AAAs were increasingly moving towards evidence-based programs, and this is really Aging Network broad, of course, with support at federal, state, local, and provider levels, of course, to move into evidence-based programs. And we've certainly the Affordable Care Act with being able to put some new mandatory dollars in Prevention and Public Health Fund to fund some of the programs that the Aging Network had already tested and demoed, such as falls prevention or the chronic disease self-management model. That's just given us greater opportunity to kind of take this evidence-based programming that we were already doing and take it to another scale and another level, and we're hoping to go even higher and get that out to more people. But what really shifted the ground beneath us all was the move by states starting just a few years ago. It feels like we've been in it forever, but I really, depending on where you are and which state, the longest it was about 3 years ago. And I remember it well because we were very shook up in DC too. All of a sudden, meeting with colleagues like Brian or others, we'd say, what's going on out there in the States? Because suddenly there were these amazing shifts towards managed care. So we are still feeling the effects of that and still working to support our members in managing that change and making sure that, again, this amazing aging network continues to play such a key role, and if anything, expands their role. And so the way we've responded to that has been to focus on helping our members. And in turn, of course, this is happening across disability networks, provider networks, to really figure out how you play in this new game. If you've done provision of Medicaid home and community services for years and years, and the entity you had to go to be able to say, I want to play that role and I want to get that money to be able to do this locally, has always been your state Medicaid office or your state unit on aging. It's a big shift to now go out and start talking to corporate providers, managed care organizations, and the like. And I want to point out before I go to, you can jump to the next slide actually now, but I just want to say one word. There is a project from the Administration for Community Living called the Business Acumen Learning Collaborative. We're proud to be a part of that. Many others are as well. And just this week they won, within the government, HHS Innovation Award. So it's awarding really cool government programs that were going on, and that Business Acumen Learning Collaborative was nominated for that. So that's pretty fast movement for a government entity in something that has just been a tidal wave of change out at the state and community level. So kudos to them, but there's still more to learn and do. This slide's pretty straightforward, just kind of giving you a sense of what we've seen as far as what this change has meant for our members. And if they weren't involved in these activities before this sea change happened, they certainly are scrambling to do so now. And at the bottom really refers to what M4A has tried to help our members focus on, which is that funding diversification and getting greater business acumen. It's almost like learning another language. Your core of your work, your mission stays the same, the incredible skill sets of an agency and its staff continue, but you have to package and market it in a different way, or you may have to have certain systems in place to be able to talk that other language with for-profit providers or more acute healthcare providers that you haven't had before. So the next slide will demonstrate just that growth I was talking about in evidence-based health programs. You can see that there was already growth before 2010 when ACA passed, but it's only kept going on that trajectory. And all the data in my slides is based on a 2013 Administration on Aging funded N4A and Scripps Gerontology Center, going to screw up their name, sorry, at Miami University out in Ohio. They worked with us on this survey. So this data is just a few years old, and I think in many cases if we were to poll again right now, which I think we'll be doing shortly, you'd see even higher growth in these numbers. And certainly what we all, I hope, would agree in evidence-based health programs is this is really what's best for people. And that's why it's evidence-based, right? It works. We know it works. But it's also been an amazing opportunity for our network to take these programs and use them as a selling point to get to know those new MCOs who are suddenly in town and swarming your state, to pitch as part of other integrated care models, to work directly with hospitals who perhaps maybe before maybe didn't give you the time of day. These kinds of programs are what they're looking for now as they look to find cost savings and to better help their clients, who are often our shared clients, achieve better health outcomes. So this is really a selling point that we remind AAAs to not only is this work important to do for all of our purposes, it can really help give you cachet in talking with other entities and making new friends. So on the next slide, this touches on one of the points I made a minute ago, which was that more and more of the services offered by area agencies on aging are not age restricted. So you can see the growth from 2010 to 2013, the gray is 2010, in this reflects asking all AAAs how many of you for these services just serve people 60 plus. So you're seeing a reduction, which at first you think would be odd, but this was age restricted. And so as the black lines go down, you see that there has been a drop off in that, which essentially on the next slide shows you it in the reverse way, which is, so what are they offering these younger clients? If they're meeting people younger than 60, what does that look like? And so if you look at this slide from left to right, you see the growth in the percentage of AAAs that are offering services. That's one way to look at it, right? So across the categories, you see this fact that every year there was a greater number of AAAs offering these services to consumers under age 60. And then what's kind of cool about this chart is you can look from the right to the left and work backwards, and that's the way you look at it to see, well, which services do they offer most often? What are the most popular ones as you look across AAAs? I don't have time to do my spiel about how AAAs are all so wonderfully unique and how that can be hard to compare them, but essentially you can see the commonality right there on the far right of that slide, in that assessment for long-term care eligibility and some health and adult day services are the most commonly offered. My next slide, also, again, all based on the same survey that we did in 2013 and released in 2014, I think really shows that this aging network is a natural fit to this new world of providing, whether it's providing information and assistance that we've always done, that coordination of care. You can see that a huge number of these services that are offered that can tie directly to healthcare delivery, such as the benefits and health insurance counseling, case management, and again, that assessment, we're already doing that work already. And certainly have the skills among staff and provider partners to be able to do. The next slide is very specific, and these numbers are not as sweeping, but remember, this has all just been growing up in large effect since the Affordable Care Act passed in 2010. And this slide, of course, shows what AAAs are, what types of integrated care, as we could most broadly define it. And you can see that the most popular is in the Veterans-directed Home and Community Services Project that has been a product of the Veterans Administration and the Administration for Community Living, and the most number of AAAs are doing that. But you can see there are others here. There are some involved with ACOs, different Medicaid waivers, and of course the duals demonstrations as well. And I would expect, again, if we were able to survey them quickly this week, we'd see much higher numbers here. The next slide speaks to, well, of those who have essentially, so far, knock wood, survived this transition to Medicaid managed care, what services are AAAs now providing under these new structures in those states for those who have completely made that transition? And you can see that the most common service offered is to conduct that initial intake and then provide that ongoing assessment. But you can see there's also a host of other things. And I think both AAAs and all of their partners across all levels of the aging network are known for being incredibly versatile, doing lots of things, usually with very little money. But that versatility, we need to continue to champion that. We shouldn't be taking two siloed systems and putting it together in one massive silo where, you know, everybody just plays one role. We believe in that flexibility. If we're going to be person-centered, we need to be able to continue to take our strengths and offer them out to the community, even if that means we're going through MCOs to be able to do that work. The final couple slides, which I think I'm running out a little bit of time here, so I'll just touch on these. I wanted to share a little bit about what we've been telling AAAs over the past few years at our conference and through other educational efforts, and some funding we get from the Administration for Community Living to be able to do this business acumen work. These are some of the strategies that we've been talking up, sometimes very strongly, to our members to make sure that people really are understanding how much the world is changing and what they need to do, not just to survive, but to be able to continue to serve and their mission and serve the people in communities. So you can see that being able to take what you already do, package it and market it in a way that it resonates with the new folks you got to sell to, and that would be managed care organizations or acute healthcare entities, you know, and it could be in your community, it could be a new ACO that springs up, and you need to go to them and say, look, through our provider network or through our senior center, standalone senior center could do this. We offer all these evidence-based programs. We want to be able to offer it to your consumers as well. I want to give a shout out to the Aging and Disability Partnership for Managed LTSS. That's that ACL grant I referred to before, and M4A is one of the lead organizations, but we do it with several groups and who are aging and disability groups working together to do this for both communities to make sure all of our providers are getting up to speed and understanding what they need to do. So my shout out will consist of their website so people can find out more. I'm not an expert in this, but we've got lots of resources at MLTSSnetwork.org, MLTSSnetwork.org. So my last slide It's been our advice to AAAs for the past few years. It may resonate with other providers. It hopefully is something that's applicable to many folks on this call as you all face these changing landscape, and we think about not only what we have to respond to, but what we'd like LTSS to look like, because sometimes that gets lost in these conversations. If you're trying to just survive in a new landscape, I think it's hard for us as policy advocates to then remember what we were trying to build before life just took over. But this is our advice, and I'm not going to read through these, but you can see that a lot of this is new. You're trying to find your new market niche in this changing environment. That's going to take new partnerships. That's going to take a different way of speaking and ways of setting up contracts. To be able to win those contracts and speak that language with those MCOs, a lot of area agencies on aging have had to set up new pricing and billing systems that don't look a lot. It's just a big shift from a grant-funded world to a contract world, and you need to be able to, of course, keep running your grant-funded programs, but set up other infrastructures internally to be able to do that. And what we very much hope and continue to stay loyal to is the idea that we do not want to change the culture of the aging network. We all believe so strongly in our mission and the many different layers of people playing these roles to ensure people can age in place and in the community as successfully for as long as possible. We don't want to lose that mission even as we're trying to adapt to change. So I think my closing remarks would be that we as an organization certainly hope that the White House Conference on Aging will help shine a light on this issue. Larry really covered the landscape of just how complex it is. There's not one solution. I'll just quickly share a few of the solutions that we were asking in our correspondence with up to Nora and her team and everyone involved through the White House Conference on Aging, that we hope that under LTSS, we've got to keep tapping the aging network. We cannot get lost in the shuffle. And Larry said it better than I could or have had time to do now, but we are concerned that we could get medicalized, and that's not in the best interest of consumers. We want to build and invest in the potential of aging disability resource centers. We want to keep supporting VDHCBS, the BIP program, all the rebalancing programs, money follows the person. And I think also we can't lose in here that one of the other key categories for the White House Conference on Aging is healthy aging. And so much of LTSS and healthy aging are intertwined. So that's the care transitions that the network is also doing a lot of. So as people transition from the hospital to home, what does that look like? How can that be successful? We want to prioritize health and wellness and continue to get additional federal dollars to do that. And ultimately, we've also got to remember that we have to improve our mobility options for people and promote community living. To keep people at home and in the community where they want to be also requires the ability to get around that community. If LTSS is really, if acute care is, I like to say it this way, it's probably too simplistic, but if acute care is your body, LTSS is your life. And that health and life really end up happening at home and in the community. And so I hope we do not lose that, and we can continue to talk about, and this is to everyone on the call, from whatever your perspective is, to keep up that drumbeat as we all get a great opportunity in July to hopefully raise the profile of aging and have this national conversation. So thank you very much to GSA for involving N4A in this conversation.
Thank you, Amy. It's really amazing all that the network is providing in terms of services to older adults out there. Next, we'll hear from Michelle Patrick. Thank you, Michelle.
Thank you very much, Larry, and thank you for allowing us this brief opportunity to talk just a little bit about the conference and our 4 focus areas, and really what we've been learning about LTSS as we've been going through this process. In the interest of time, because I know we want to get to our questions, and we have a few hundred people on the line who are very eager to hopefully ask some questions, just let me give a few brief remarks. And I just want to say we all know that the U.S. is experiencing incredible transformation. Tens of thousands of baby boomers are turning 65 every day. Well, this 2015 White House Conference on Aging, it's really intended as a national conversation about the issues most important to older Americans and their families in order to help inform this changing aging landscape in America for the next decade. So, over the past year, as Brian alluded to, we've had 5 regional forums, Cleveland, Phoenix, Boston, Seattle, and Tampa. We've conducted over 100 listening sessions and meetings around the country, and through a lot of other opportunities, we've really been on a journey of listening, of learning, and of sharing with older adults, their families, caregivers, community leaders, and experts in the aging field on how do we best address this landscape. And throughout our discussions and dialogues, really 4 topic areas have emerged, and they're going to provide the focus for the national conference, which is being held July 13th in Washington, D.C. And as you can see on the screen, our 4 focus areas begin with retirement security. Now, historically, a secure financial foundation for retirement was sort of envisioned as a 3-legged stool: Social Security, pensions, savings, and investments. But as we know, private pension options have changed, and fewer workers spend their careers with a single employer. Therefore, the sources of retirement security are changing too. And the White House Conference is going to give us the opportunity to look at this and to see what the future may hold. But as we're doing that, we're not only interested in helping ensure financial security for older adults, we also want to ensure that they remain active and independent. And in many ways, this goes hand in hand with the whole LTSS conversation that we've been having. That's why our second focus area is healthy aging. We know that if we want to improve our odds of living longer and in good health, we need to exercise, eat well, limit stress, get sufficient rest, challenge our minds, engage in social activities, and connect with family and friends. And that really provides a foundation for good health, not just in older years, but throughout life. We also, in healthy aging, we need to enjoy regular preventive health screenings and immunizations. And primary prevention in later life also includes reducing risks for preventable injuries such as falls. And that's a significant cause of disability. Falls affect 1 in 3 older adults every year. As part of healthy aging, we're also looking at the ways to best manage chronic conditions, and we need to ensure healthy communities. And we at the White House Conference on Aging are not only working with all of our colleagues in HHS and throughout the aging world and the various organizations, but at HUD and transportation to ensure that our communities they allow seniors, older adults, access to various services, and they allow them to get exercise, etc. It was that one of the events that we had earlier this year, it was the Surgeon General, who made the point that healthy aging really depends on healthy communities. So our third focus area is elder abuse, or preventing abuse, neglect, and financial exploitation of older adults. We know that elder abuse undermines health and hope. And as Americans live longer and technology becomes increasingly sophisticated, older Americans can be more vulnerable to scam artists and others seeking to exploit them for financial gain, as well as vulnerable to abuse and neglect. Elder abuse occurs across the socioeconomic spectrum. It can occur in older adults' own homes, in family homes, or in nursing homes. And ultimately, it not only affects whether an older adult has a long life, but a good life. And finally, our fourth focus area, which is the topic of our conversation today, is long-term services and supports. Because we know that, despite the fact of how healthy we hope to remain, eventually many older adults will develop some limitations and simply need some very basic care with everyday tasks. Next slide, please. Now, Brian already sort of went over the landscape of the numbers. We know that an estimated 12 million Americans currently need long-term services and supports, and by 2015, that number is going to double. When additional help and support is needed, it's generally provided at home by unpaid caregivers. Again, something we're all very much aware of, but a couple of things I want to note. In 2011, which is again our last point in time, this unpaid care was valued at $234 billion a year. And, for the most part, is provided by family and friends. And we have a paper out on our website, and you will see the web address at the end of our conversation, but it's whitehouseconferenceonaging.gov. And one of the resources that you will see there is we have produced 4 policy papers, one on each of the topic areas of the conference. And we do have one on long-term services and supports. that goes over informal caregiving, paid caregiving, long-term services and supports, planning, financing, etc. And I just want to note one or two things that you will find in that paper. For one, there are a number of federal resources that are available to help with caregiving. The Administration for Community Living, which is within the Department of Health and Human Services, it has resources for caregivers through the National Family Caregiver Support Program. And if you go to that, you will find information about available services, counseling, and respite care targeted to caregivers. It also, the U.S. Department of Veterans Affairs, provides resources to caregivers of veterans through its VA Caregiver Support Program. And if you go to that paper on our website, you will find that and a lot more resources. And I just want to note that this is an issue that not only the White House Conference on Aging, but the administration in general is very focused on. And the President's 2016 budget, for example, continues to emphasize the importance of caregiver supports and includes nearly $50 million in new funding for aging programs that provide critical help and supports to older adults and their caregivers. Of course, to tangent, when we're discussing long-term services and supports, it's about 35% of older people, which I do believe that Brian alluded to as well, pay for long-term services, which raise issues of access, affordability, and quality. But for those who must pay for services, the average cost of a nursing home now is about $1,800. The average cost for services in the home are about $1,800 a month, and nursing homes cost anywhere from $70,000 to $80,000 a year. Of course, Medicare does not cover most long-term care. Medicaid pays only for services for people with limited financial means, and unfortunately, less than 3% of Americans have a long-term care insurance policy, which can be costly and difficult to purchase. And I note all of that because when it comes to long-term care services and caregiving, there's issues, of course, of access and financing, but also about planning and education. And we need to get the word out that we need to start thinking early about this in the same way that we start thinking about retirement security. Okay, next slide. Well, over the past year, as we've been doing our work around the country, our listening sessions and such, we've been soliciting feedback on all 4 of our focus areas from the public. And today, for really the very first time, I want to share with you the themes and major policy goals that have emerged in long-term services and supports. And they've been suggested from input from the 5 regional forums, comments on our websites, listening sessions, and responses to the long-term services and supports policy brief that I alluded to. And what's remarkable is the consensus that has emerged in each of the areas in terms of what needs to be done. And I do want to note that these are not, I want to stress that these do not represent formal policy or programs of the White House or the White House Conference on Aging. This is just what the public has been telling us. And the 3 themes that have emerged in the area of providing long-term services and supports are, first, we need greater support of formal and informal caregivers, including family support programs. Second, we need a sustainable long-term care financing model. Comprehensive reform should provide continuity of care from acute to home care settings for all income levels and should help alleviate financial burdens on older adults and their families. And finally, third, we need to advance person-centered care that maximizes independence and choice. Such care will focus on the well-being of the whole person, and it moves away from the medical models of care into community-based settings. And I think all 3 of those ideas that have emerged were very much noted by both Amy and Brian in their presentations, and I think it's very much what older adults and their families want. Next slide. So in conclusion, really the White House Conference on Aging is going to provide a national forum to discuss the various aspects of long-term services and supports, as well as the challenges that are inherent in all of our 4 focus areas. By doing so, we do help to reshape the aging landscape in America in order to best ensure that older adults enjoy not only longer lives, but better lives. Next slide. And to help do this, we really hope you'll get involved. We see the conference as an ongoing dialogue, and we want your voice as part of the conversation. If you haven't done so, visit our website that I noted, and the address is up there. Sign up for regular updates, and please provide us your thoughts on the issues and opportunities that you see in aging. As Larry noted earlier, the July 13th event is by invitation only, but there are still many ways to get involved and ensure that your voice is heard. You can watch the live web stream. You can host a watch party. You can participate in a Q&A using Twitter with experts. And I really want to note there are more ways as well on our website. And just finally, before concluding, in everything that we've done this year, including our regional forums and the run-up to the conference, many organizations, but particularly AARP, has been played a significant role and has supplied us with significant support for everything that we've been doing and has been instrumental in providing for the conference. So, in a nutshell, that's what we are doing for the conference. That's what the conference is about, and that is what we've been hearing through the various conference venues in terms of long-term services and supports. Thank you.
Thank you, Michelle. That was great. Very impressive, all the information you've been gathering around the country. Well, we don't have very much time left, so I'm going to try and get a few questions in here very quickly, and I'm asking my panelists to give very short answers. The first question I'm going to throw at you, Amy, and that is, what is the possibility of getting CMS to include ADRCs in case management and assessment reimbursement process? It would be good to have the client assessments done for all the people who we serve.
Oh, way to stump me in the get-go. I'm not sure I can offer an opinion on that. I mean, obviously, that's part of our challenge is to, I feel, be known. We have amazing allies in the Administration for Community Living and the Administration on Aging, and I think part of the network's challenge has been to speak very frankly, to get CMS to treat us seriously. We look different, we act different, we use different terms. We're still serving those same populations. So if you have suggestions for how we can do federal advocacy to better get opportunities there for the Aging Network that was one specific example of how to make sure we can tie in and do that work, we would love to get it. There's lots of room for growth there.
Okay, another quick one. Maybe I'll start with you, Michelle. One of the questions is about the lack of dental coverage, either under Medicare or long-term care. Did that come up at all as an issue around the country? And feel free to chime in, Larry, if you'd like to comment.
Mm-hmm. Yes. Obviously, we know the importance of dental care to overall good health and to healthy aging as well. And that has come up. I cannot say that it came up in every conversation, but it has come up in a subset of conversations as something we should look at as we go forward for Medicare and Medicaid policy.
Great. Thank you. A couple quick questions. When was the last White House Conference on Aging? That was 2005, and there was one in 1995. Greg O'Neill asks me to make sure that you know that you may get the slides already at www.geron.org/webinar. And let me throw one back to you, Amy, and that is related to the AAAs. In the slides that show the increases in AAA services, does home care mean medical care provided in the home or non-medical home care services?
Okay, that depends on the slide. We've got homemaker, we've got home health would be healthcare. Homemaker services, I'm trying to think, there was a place we just used the more casual home care. We usually differentiate it by homemaker being those supports, chore services, helping support someone being able to live in their house, very separate from home health, which is just as it seems. I'm trying to look and see if there was another place we used it, but feel free to email me this. My email is a.gottwals@n4a.org, and I can follow up with a more thorough answer.
Likewise, my email, this is Brian, is brian@consumers.org, and I would be happy to, since we're running out of time, to try to get answers for your questions as well. So let me just, on behalf of the Gerontological Society of America, thank our speakers and thank all of you for participating today. A special thanks, obviously, to excuse me, the SCAN Foundation for providing support for the program and the webinar today. Just another reminder that, again, this has been recorded, and you'll be getting an email to show you the access link once it's available. And finally, there is a short 10-question webinar service that will automatically launch when the webinar is over. So please, if you're willing, provide us with feedback by clicking the survey link at the end of the webinar so we can try to make improvements. I noticed that one person wrote the comment that we should have closed captioning, and I don't know the technology behind that for webinars, but I am sure that we will try and do that for the next time. I thank you all, and have a great day.